Hi, everyone. So this is Dr. Rhodes. I'm one of the MGH Pediatric Neurology residents. Today, we're joined by Dr. Helen Cross, and I'm here to give her intro. So thank you for joining us. Professor Helen Cross is the Prince of Wales's Chair of Childhood Epilepsy and Director of the University College London Great Ormond Street Institute of Child Health, and an honorary consultant in pediatric neurology at the Great Ormond Street Hospital for Children. Her research has been targeted at improving outcomes in early onset epilepsy, specifically in assessing the role of surgery and ketogenic diet. She has held key leadership roles both nationally and internationally. She's previously been elected as the president of the ILAE, is currently clinical advisor to the National Children's Epilepsy Surgery Service, and developed as coordinator the EpiCare network. She's published over 450 peer-reviewed publications, reviews, and book chapters. Thank you for joining us.
Thank you very much, and thank you for having me. And I know there are people I know in the audience, so hello to them. Thank you for having me remotely. Just to go over these slides, which I understand you have all seen. So what I'm going to do is talk a little bit today about the changing landscapes in the developmental and epileptic encephalopathies. Things are moving very fast, and it's just to give a bit of an overview about where we think we are at the moment, although things are changing day by day. So these are my disclosures. So I'm going to talk a little bit about the concept of developmental and epileptic encephalopathy and how things have changed, the importance of diagnosis, how that then we may look at optimizing treatment algorithms, moving towards looking at targeting treatments more in the way of precision therapy, and then a little bit about what this means for the future. So if we remind ourselves with regard to the classification framework of the epilepsies, there's no question that, of course, the first thing we wish to do when we meet a child with epilepsy is look at what seizure types they are experiencing and even the epilepsy types. Ultimately diagnose an epilepsy syndrome where possible. We've long known that particularly with the early onset epilepsy syndromes, it's not only the seizures that are problematic, but also various comorbidities, what we call comorbidities, but more accurately, probably because it's so integral to the disorder, we really should be calling them multimorbidities, but such as learning and developmental problems, behavior problems, amongst others. And increasingly, we are becoming aware of the underlying cause of the epilepsies. The epilepsy not being a single disorder, of course, but a symptom of many different disorders. And we now divide the etiological categories into structural, genetic, infectious, metabolic, immune, and unknown. But even though in pediatrics particularly, we've long known about epilepsy syndromes, and indeed in the International League Against Epilepsy, we've talked about this since, since first descriptions of childhood absence, and indeed even ultimately Lennox-Gastaut. There's never really been a formal acceptance of what may be classed as each individual epilepsy syndrome. So in the ILAE term of 2017 to 21, a task force was put together to try and look at all the evidence base with regard to what would be included with relevant syndromes, and indeed put formal criteria for diagnosing such syndromes. This resulted in 5 papers, an initial paper summarizing the situation, but also outlining the methodology, not least a full literature review, a review of well-renowned texts, as well as Delphi consensus amongst adult and pediatric expertise. And then another 4 papers, one paper on epilepsies with onset in neonates and infants, another with regards to epilepsy syndromes with onset in childhood, those with epilepsy syndromes with onset at variable age, and ultimately a separate paper, which I won't be dealing with here, but on the idiopathic generalized epilepsy syndromes, recognizing that this includes 4 well-defined syndromes that have a very specific diagnostic criteria and ultimately prognosis. But other concepts that were dealt with within the paper included what we might call an epileptic encephalopathy and ultimately a developmental and epileptic encephalopathy. The term epileptic encephalopathy has long been utilised, probably first utilised by Gastaut when he was originally describing the children and adults that they saw, which ultimately were diagnosed with Lennox-Gastaut syndrome, not least the fact that they were normal prior to presentation. They present with their seizures, and with flurries of seizures and a highly abnormal EEG, there was an associated developmental plateau, if not regression. And therefore, it was perceived that the epileptic activity was contributing to the overall developmental concerns. Although we went through a phase of relating this term to some specific epilepsy syndromes, it became clear that this really is a concept and not actually a disease, in view of the fact that it can apply to any of the epilepsies to varying degrees, acknowledging there are some epilepsies where it will be seen in a more prevalent fashion. So the epileptic encephalopathy was defined in the 2010 paper, where epileptic activity itself contributes to severe cognitive and behavioural impairments above and beyond what might be expected from the underlying pathology alone. But recognising, of course, that it's not all the epilepsy, and with the perception that perhaps if we call a group of epilepsies epileptic encephalopathies, there's the perception that we just get rid of the epilepsy and then everything will be okay. It's clear that the pathology, the underlying pathology, also has a contribution to the overall neurodevelopmental outcomes. And so in 2017, the concept of developmental and epileptic encephalopathies was first put forward and subsequently confirmed with definition in 2022, where there is a developmental impairment related to both the underlying etiology, independent of epileptic form activity, and the epileptic encephalopathy. So we have the term epileptic encephalopathy is where the seizures and epileptic form activity is having an impact on development. The term developmental and epileptic encephalopathy, where it's both the underlying cause and the epileptic activity. And of course, there will be individuals where they have an underlying cause as the major cause of the intellectual problems, the developmental problems, and they may have a coincidental epilepsy, which isn't having an impact. So when we think about underlying cause, of course, there's been an absolute explosion of underlying gene variants that have been reported to be a cause of a primary epilepsy. And this has really accelerated over the past 10 to 15 years. And this is specifically relevant to the developmental and epileptic encephalopathies. Not least, this is a gene curation that was undertaken and published in 2023. And you can see that they actually reported on in excess of 900 genes as a cause of monogenic epilepsy. And this was particularly relevant in the developmental and epileptic encephalopathies, with a definitive increase seen over the past or the previous 10 years. And of course, with many of what we now call the developmental and epileptic encephalopathies with onset in childhood, but with an understanding of the underlying gene variant, then we gain more of an indication as to the possible underlying pathophysiology. So we're getting an increased awareness of what we now call trans-channel transporter defects, the syntactopathies, and cell disorders of cell signaling and metabolism. And this may become relevant as we move forward in thinking of best ways in management. But of course, these developmental and epileptic encephalopathies may also have a structural cause. And a classic form of this is that related to hypothalamic hamartoma, where they present with early onset gelastic seizures, but then the situation may evolve with time to develop other seizure types, particularly an abnormal EEG and various comorbidities, psychiatric disorders, rage attacks, neurodevelopmental problems, sleep disorders, and which we know that it's only disconnection or ablation or removal of the hamartoma that will lead to an overall improvement. But also focal lesions, particularly in early childhood, can cause developmental and epileptic encephalopathy. Not least this a focal lesion in the temporal lobe that caused a late onset of spasms with a non-localizing and slow EEG, and indeed burst suppression effect in sleep. And this, another child who presented with infantile spasms related to a focal cortical dysplasia. The spasms responded promptly to treatment, but with time, with the emergence of focal seizures, neurodevelopmental problems became evident. And again, although surgery was undertaken relatively late, improvement was only seen after that. So we are now coming into a realm of defining etiology-specific syndromes, and not least where we have specific phenotypes in relation to specific underlying causes, then it may be that we should be referring more to an etiology-specific syndrome than an electroclinical syndrome. And this may be genetic, such as with CDKL5 developmental and epileptic encephalopathy, or PCDH19 clustering epilepsy, or indeed structural, as with gelastic seizures with hypothalamic hamartoma. Although we also may see it to some degree in immune or inflammatory conditions such as Rasmussen syndrome. And the reason for really picking up on these distinct phenotypes and having a clue with regard to the underlying cause is that we'll be able to allow earlier a recognition of such syndromes if and when precision therapies become available. So just to emphasize, we have the umbrella term developmental and epileptic encephalopathy. And from within that, there may be an electroclinical syndrome, such as early infantile developmental and epileptic encephalopathy, or infantile epileptic spasm syndrome. Or there may be an etiology-specific syndrome, such as with CDKL5 DEE or hypothalamic hamartoma with gelastic seizures. But of course, in some, there may be two such diagnoses, and which also may both help as we move forward. So why does this matter? Well, of course, when we look at the developmental and epileptic encephalopathies, seizures aren't the only problem, and that's the whole concern around the underlying concept. There may be a range of other morbidities that are integral to the condition and may have equal or even more of an impact in the individual than the seizures themselves, whether that be in neurodevelopmental progress, behavior, movement and gait disorders, gastrointestinal problems, sleep, or other indeed problems. And the whole issue is whether we can actually influence that outcome, whether it be the underlying cause or indeed the epilepsy causing the overall problem. And of course, we also have to think about whether the medication may be having some impact. So have we got evidence of us making a difference? Well, first of all, let's look at infantile epileptic spasm syndrome. This is a disorder whereby we all recognize this in a presentation in infants, usually around between 3 and 6 months, presenting with spasms, recurrent clusters of spasms, usually related to the sleep-wake cycle, so on waking or indeed going off to sleep. And in many, this may be associated with a highly disorganized, high amplitude EEG that we call hypsarrhythmia. And previously, when we were looking at the triad of infantile spasms, hypsarrhythmia, and developmental plateau occurring often either before or just after the presentation with spasms, we know that this forms a syndrome for which in the longer term, 85% will have developmental compromise and 60% ongoing seizures. But with careful delineation of this syndrome and recognizing the prognosis over time, we also recognize what treatments may be optimal with regards to cessation of spasms. In treatment of tuberous sclerosis-associated spasms, vigabatrin has been determined to be extremely effective. But in randomized controlled trials looking at spasm presentation not associated with tuberous sclerosis or other structural malformation, in the UK infantile spasm study, it was demonstrated that steroids were more effective than vigabatrin in achieving immediate remission, although there was little difference in the longer-term relapse rate. But and the more recent International Collaborative Infantile Spasm study, it was demonstrated that vigabatrin with steroids started at the onset was more effective than steroids alone in short-term remission and indeed sustained remission. And why is this important? Well, we know improved outcome in the longer term is related to a short treatment lag, namely a short time between diagnosis and treatment start, a prompt response to treatment. We are aiming for seizure freedom and a normal EEG, and a shorter duration of hypsarrhythmia. This may be considered to be an archetypal epileptic encephalopathy or a developmental and epileptic encephalopathy, where the epileptic abnormality is contributing to the developmental problems, and the shorter duration of that certainly is associated with better long-term neurodevelopmental outcomes. But we're not doing very well. We'd like to think in this day and age where there's good recognition, we will be able to treat these children properly. But this study, admittedly 2017, was a study from LA where they looked at 100 individuals who presented with spasms to their clinic to look at the time between diagnosis and indeed treatment, and what effective treatment and indeed what influenced that. And the mean time of onset of spasms to the time of getting between onset and indeed getting to an effective provider was actually 24 days. That's more than 3 weeks. And only 29% met an effective provider within 1 week of spasm onset. There was no doubt that language preference had an influence on that, but it shows that we can still do better in our recognition and treatment of these patients in order to optimize our outcomes. And of course, there has been the big debate about whether we can utilize preventative treatment, and particularly where we know there's a high risk of spasms. We know in tuberous sclerosis that seizures are highly associated with the prevalence of the intellectual disability. And with the initial EpiStop trial, which was the European study with participation from Australia, where they looked at preventative versus active treatment, so preventative monitoring babies from birth known to have tuberous sclerosis and either treating as soon as an EEG became abnormal or indeed at the onset of spasms. And there was a randomized group and an observational group. The observational group is where families chose whether they wanted to be on preventative or indeed conservative treatment. And what this showed was actually, yes, there was a delay in or even a reduction in numbers of children who presented with spasms, and there were more in the way of seizure-free patients at 2 years. And spasms indeed were prevented, but there were indeed no initial differences with neurodevelopmental outcome at the 2-year mark. And with the PREVENT study, with slightly undertaken in the US with slightly different methodology, again showing that there was no difference in months to first seizure between the conservative and the preventative group, although there was a difference in months to first infantile spasms, so an apparent prevention of infantile spasms, but again, no change in the initial neurodevelopmental outcome. So what about other early onset syndromes? Well, how about Dravet syndrome, a syndrome that we now know quite a lot since its first description in 1978 by Charlotte Dravet. In these children, they present with initially normal from birth, but then they present in the first year of life with febrile and afebrile generalized and unilateral, usually hemiclonic, prolonged tonic or tonic-clonic seizures, normal neurodevelopment in that first year, but then in later appearance in the second year of myoclonus, atypical absence and focal seizures. And with that, the developmental delay becomes progressively apparent. The gap between them and their peers widens, and so they appear to decrease their IQ. And prognosis is always unfavorable, both for seizure control, cognitive development, and there are higher mortality rates than other children with epilepsy. And with careful delineation of the phenotype, we know that more than 90% have variants in the sodium channel gene SCM1A, loss of function variants on chromosome 2. Again, with time and delineation of the phenotype, different trials have been undertaken and indeed algorithms formulated with regard to treatment, knowing which treatments are likely to benefit these children. And of course, the other issue is not only the treatments are likely to benefit with valproate and then fenfluramine, stiripentol or clobazam, and ultimately pharmaceutical grade cannabidiol, but also the need to avoid sodium channel blockers, particularly carbamazepine and oxcarbazepine, but to some degree lamotrigine. We know that this is a lifelong condition. It's an archetypal developmental and epileptic encephalopathy. We know that there are other morbidities in addition to the seizures, not least increasing gait problems, feeling problems, sleep problems, and of course the high prevalence of SUDEP compared to other disorders. So one of the key questions has long been, can we have an impact on cognition? These are on the left are on the top are standard trajectories of individuals with Dravet syndrome. And you can see that IQ drops over time, not least because they are not making progress, and therefore the gap is widening between them and their peers. You can see in the bottom graph that in this particular study from Italy, they did note some individuals who did not appear to have the same trajectory. And they looked at clinical features between the two groups and demonstrated that actually there was no difference, not only in the genetics, but also in the episodes of status epilepticus, frequency of seizures, medications, and indeed, the only difference was in those with a decreased trajectory, they had slightly more greater prevalence of myoclonus. And subsequently, again, recognizing that Dravet syndrome is predominantly electroclinical phenotype, we know that it can be associated with other gene variants. Rena Nabu, in her series, demonstrated that in the SCM1A variant group, there was more significant cognitive delay than other genetic variants, and demonstrating that it was SCM1A was a key factor of cognitive delay in addition to the epilepsy. There have been animal studies with knockout of the SCM1A gene in the prefrontal cortex, and thereafter showing developmental problems in the animals without the development of epilepsy, and therefore again confirming that this is a developmental and epileptic encephalopathy. But another thing that we can do, however, is that, again, this is another study on the right from Denmark, where they looked at trajectories of children with Dravet syndrome over time with regard to their cognition. And they looked at the utilization of contraindicated medication in the first 5 years of life. And what they showed is that actually those that had utilization of carbamazepine for more than 11 months in the first 5 years of life had lower IQs in the longer term than those, which are the blue line, who'd had the medication for less than 11 months, making it very important that we need to avoid contraindicated medication if at all possible. So then we come to the need for a prompt and early diagnosis. We now have the criteria as laid out by the International League Against Epilepsy with regard to criteria for diagnosing Dravet syndrome. The bar on the left with regard to the tick is actually where the actual mandatory features, namely recurrent hemiclonic seizures, focal to bilateral tonic-clonic and or generalized tonic-clonic seizures occurring between the ages of 1 to 20 months, onset 1 to 20 months. And on the right, red flags, not least to say that these are exclusionary for the diagnosis, namely epileptic spasms, or an MRI showing a causal focal lesion. Whereas those in the middle, there's an exclamation mark, but these are features that if they're present, they don't exclude the diagnosis, but should just make us think, is it the diagnosis? Such as no history of prolonged seizures, lack of fever sensitivity as a seizure trigger, developmental delay at seizure onset, focal neurological findings, or lack of a pathogenic SCN1A variant or other causal variant. Our problem is that we still have children being referred who perhaps present in the first year with prolonged hemiclonic seizures, and then perhaps the diagnosis hasn't been considered, and thereafter are treated as early onset focal epilepsy, and therefore may be treated with the wrong medication. And there may be also the added concern about when do we decide that this is a Dravet syndrome, when in the natural history, after a prolonged or a hemiclonic or tonic-clonic seizure, or indeed an episode of status epilepticus in the first year. We've long known that the age of onset is helpful. Presentation before the age of 6 months is likely to be associated with the ultimate diagnosis of Dravet syndrome, although the gene variant is also helpful, truncating variants seen more frequently in Dravet than missense, but that doesn't mean to say missense aren't seen. And this is a study undertaken, led by Andreas Blumklaus, where they developed a prediction model for early diagnosis of SCN1A-related epilepsies. Those in the purple actually with a high probability of developing Dravet syndrome, those in the grey probably genetic epilepsy with febrile seizures plus. And therefore, and this is available, that we can just put in the gene variant, put in the age of onset, and look at the likelihood that this is going to be Dravet syndrome. And this is important. And important because of the treatment algorithms, as I've already highlighted, but also because we're moving towards therapies that I did not think I would be seeing in my lifetime, and that is genetic therapies. And this gives a key example. This is the ASO, the antisense oligonucleotide therapy for SCN1A variants, not least. This is where it enhances the normal protein, knowing that they are heterozygote. And this is demonstrated with intrathecal injection to reduce seizures and SUDEP incidence in a mouse model of Dravet syndrome. Now moving to the clinical arena with the safety and tolerability studies, as well as dose finding, with Monarch in the US and Admiral in the UK, moving to the open label studies of Swallowtail and Longwing, showing that with a higher initial dose, benefit with regard to seizure reduction, but also demonstrating improvements in the short term over and in the neurodevelopment and Vineland's particular, over and above what has previously been seen over 12 months in a natural history study. Tantalizing data, but obviously now moving to phase 3 studies. So that brings us on to the whole issue about precision diagnosis and precision treatment. And knowing the underlying genetic variant, as I've said, could give us an indication of the pathways and proteins which are coded for, and therefore give ideas as to how we may move towards alternative treatments to our routine anti-seizure medications, more targeted treatments that are guided at the targeted at the underlying pathophysiology. And that may be etiology targeted, such as supplementation or genetic therapies, or indeed pathophysiology targeted, perhaps repurposing medication, such as in the channelopathies or indeed genetic pathways. And there may be different ways we can think of that. I've mentioned the mRNA, namely the ASO effects with recurrent intrathecal injection, but also they are now looking at DNA therapies, not least AAV therapies, may also consider perhaps CRISPR editing, looking at having an influence on the protein, such as with sodium channel blockers for certain gain of function sodium channel disorders, or more recently L-serine for loss of function grin disorders. Maybe looking at the pathways for which are coded for, such as ketogenic diet and GLUT1, or indeed looking at mTOR inhibitors in disorders of the mTOR pathway. And indeed, ultimately, you could almost think of network targeting with regards to such as neurostimulation, although that perhaps isn't yet thought of to be a precision therapy. So just to give some examples, we can look at glucose transporter deficiency syndrome. This is GLUT1 is one of 9 glucose transporters coded for by the SLC2A1 gene. And this may present in a range of ways, not least with an early onset developmental and epileptic encephalopathy, even later with early onset absence. And ultimately, of course, there are a group of individuals with paroxysmal movement disorder. We can think of clues to the diagnosis, particularly in infancy, whether we look at eye-head gaze saccades, now recognized as pathognomonic, or even microcephaly that's present in 50% of cases. And now most of these will be diagnosed through genetics, not least as determining the SLC2A1 variant, although of course they do have a low fasting CSF glucose or a CSF plasma glucose ratio. We know that actually treatment with a ketogenic diet will treat the epilepsy in the majority of cases. Not least, we're providing an alternative fuel for the brain, bypassing the glucose transporter because we cannot take glucose up into the brain, and ketones thereafter getting into the brain to provide the energy source. And there's some evidence, albeit limited evidence, that early diagnosis and initiation of the ketogenic diet may improve cognitive outcomes. And certainly that's something we see in clinical practice. Tuberous sclerosis is another condition whereby we may look at the pathway, not least looking at mTOR inhibitors. We know that variants in the TSC1 and or TSC2 gene means that the complex leaves the mTOR pathway unchecked, and we get the overgrowth of tissue that we see in various organs, not least the kidney and the brain. Yes, the tubers in the brain may be causing the seizures, pathologically no different to cortical dysplasia, but we also know that it may not only be that. And indeed, the EXIST trial actually definitively showed that we may get benefit in the epilepsy, treating the focal seizures, utilizing everolimus. And as you can see in the study, it actually got incremental effect called with dose increase. And indeed, there appeared to be a progressive improvement over time. Other mTOR inhibitors have been utilized, and this is just a study of one of my colleagues where metformin has been utilized. At first, they looked at the renal angiomyolomometer and indeed a randomized double-blind placebo-controlled trial with the primary outcome of the size of the renal lesions, but as a secondary outcome looked at seizure response and indeed demonstrated seizure reduction in the metformin group, and indeed this is moving to randomized controlled trial. And it may be that we don't have to look too far for effective medications if we think about the underlying pathophysiology. And if we look at some of the disorders that are associated with gain of function sodium channel mutations, such as SCN8A or SCN2A, and indeed the developmental and epileptic encephalopathy associated with KCNQ2 mutations, it has been determined that sodium channel blockers, namely carbamazepine or phenytoin, can be incredibly effective as they suppress the function of the gain of function sodium channels. And indeed, in KCNQ2, the sodium channels are co-located with the potassium channels, and hence why it's thought to be of dramatic benefit. We don't traditionally, we have not utilized sodium channel blockers to a great degree in the first year of life, but this is an area where we really have to think about it. Although it's not entirely straightforward, because in SCN2A, there's no doubt that early onset infantile developmental and epileptic encephalopathy is associated with gain of function variants, but there is a later presentation associated with autistic spectrum disorder, possibly with not so severe seizures, where it's associated with a loss of function missense mutation. Thereafter, that's not going to respond to sodium channel blockers. So if there's an aggravation of seizures, we have to bear this in mind. Increasingly, we are finding that we may be able to repurpose various medications to treat the disorders which we find associated with the various gene variants. And although this list is growing, however, we do have to remember that this is only a small number when you think about the number of monogenic epilepsies we are now aware. And even when we think that we can treat the disorders, it may not be that straightforward. And I relate to this paper, not least because the boys at the bottom of this table were the younger brother I treated. He presented with severe atypical absence epilepsy, in fact, epilepsy associated with eyelid myoclonia, with a lot of self-stimulation and marked intellectual disability and indeed behavior disorder. I looked after him through childhood. I knew his brother had a severe behavior disorder without epilepsy, to the extent that he could not live in the home setting. Tried various medications over the years. I indeed investigated him, or it was before the time that we had genetic evaluation fully available. And when he was 26 and I'd handed him over to adult care, I was telephoned by the adult team to say they had identified a homozygous mutation in GAMT and diagnosed a disorder of cerebral creatine metabolism. They initiated creatine supplementation, and his seizures stopped for the first time since presentation at 7 years, and his anti-seizure medication was totally withdrawn. However, his behavior deteriorated to the degree that his family decided they wanted him to be having seizures and not on the creatine supplementation than actually being seizure-free. And then there's this girl who I'd looked after since the age of 3 months, when she first presented with tonic seizures. These were initially monthly, multiple admissions by 12 months with clusters of seizures. And as she underwent a full investigation at that time and MRI, and no real cause determined. She went through a variety of different medications, you can see, including immunoglobulin, and ultimately had some respite from felbamate, but she still continued to have recurrent annual admissions for frequent clusters of seizures and developmental regression. At the age of 8 years, her geneticist rang me and said, could an SEN8A mutation be relevant? I initiated carbamazepine. She'd never been on this previously, and she became seizure-free for the first time. And at 13, between the ages of 8 and 13, she experienced one brief seizure with a chest infection. She essentially remains seizure-free. However, she remains non-ambulant, non-verbal, although she's interactive and has a good quality of life. Her parents repeatedly ask, what if we had made the diagnosis earlier? So this is the question we've raised as a part of an international consortium study. We have an international precision child health partnership between Boston, Toronto, ourselves, Great Ormond Street Hospital, and also Melbourne Children's and the Murdoch Institute. And as one of the flagship project with this has been Gene Steps, which is evaluating all children who present in the first year of life with seizure onset, where there's no obvious etiology, with rapid whole genome sequencing. By rapid, we get the answer within 3 weeks. They're having neurodevelopmental assessments, recording whether a decision is made with regard to treatment, and thereafter we hope to follow to 3 years of age. And the first 100 patients, now we've actually got up to 400 patients in excess of now, the first 100 patients and the results of those were published in the Lancet Neurology in 2023. And what this showed was that there was 43% diagnostic yield after the initial clinical analysis. Genetic diagnosis had an immediate clinical utility, informing treatment in 56%, additional evaluation in 65%, prognosis in 86%, and recurrence risk counselling in all cases. And it wasn't only looking to see whether we were changing management with regard to the good and giving a more optimal treatment, but also here, such as here, in where we don't have a treatment And we know the likely prognosis, and we led to redirecting care. And this child who was born at 31 weeks, was very sick, deteriorated day 5 with apneas, focal seizures. The gene STEPS result after 15 days demonstrated a biallelic BRAT1 nonsense and frameshift mutations. We know that's associated with an extremely poor prognosis with regards to neurological and developmental outcome. And with regard to this, intensive care was redirected after discussion, and we were able to give genetic counselling and IVF implications. But as I've said, we're not there yet with precision treatment for everybody. And I put to you in this case, who's a boy came to us aged 11. He'd had his first seizure at 10 months, focal seizure, increase in frequency up to 8 to 9 a day, evolved to recurrent jerks, more prolonged stiffening episodes from sleep, and ultimately the stiffening episodes were causing him to drop by day. He'd trialed numerous medications, and the question as he came to us was, what next? He was known to have a gain-of-function SCN2A mutation, but had not responded to sodium channel blockers. On evaluation of his clinical history, his stiffening episodes being tonic seizures, both from sleep and by day, and looking at his EEG with slow spike and wave, both with and without associated clinical features, and stiffening episodes in sleep, as well as the paroxysmal fast in association with this. We were able to give him the diagnosis of Lennox-Gastaut syndrome and direct him to treatments that have been licensed for this particular syndrome, not least cannabidiol and now fenfluramine. And now again, even with electroclinical syndromes, we can revert to the algorithms that we know where medication has been useful, whether it's demonstrated to be useful, and indeed look at not only the medication sequences, but also other non-pharmacological treatments, not least ketogenic diet, vagal nerve stimulation, and callosotomy. So where are we now, and how do we move forward? Well, certainly it's becoming very exciting with regard to the genetic epilepsies, not least looking at genetic therapies. We are looking at the first RNA therapies. There's also a viral vector therapy that is being utilized in Dravet syndrome in a dose-finding study, and looking at repurposing medications and small molecules. If we look at the near term and maybe over the next 5 years, maybe we can look at peripherally delivered gene therapies. We can look at next generation AAV capsids, redosing, immune management strategies, and even combination approaches. And ultimately, in the longer term, genome editing, epigenome editing, and programmable cell-specific delivery. But we also need to determine where these individuals are. And yes, there are increasing registries to determine where children with specific gene variants may be. But also we need to look at natural history studies. What is the impact, going to be the impact of our changes in treatment and our precision therapy approaches? Are randomized controlled trials going to be the approach in all? We really do need to look and see whether we're changing the natural history over time. But we also have to return to the fact that we haven't got precise therapy for all those that have developmental and epileptic encephalopathies, and raise the question, do we need to undertake trials in each individual electroclinical syndrome? The heterogeneity of inclusion for many trials make this a bit of a nonsense. And in some of those that have been trialed in specific syndromes, such as cannabidiol, you know, it doesn't have there's no evidence there's a specific action in these syndromes. They've just gone for orphan status, and therefore in countries where they may be limited by expense, then we're only able to utilize CBD in these particular syndromes. There's been the recent designation of breakthrough therapy status for bexicaserin for patients with any type of developmental and epileptic encephalopathy, this being the umbrella term and must be the way to go forward for many of those that don't fit into a specific syndromic category. But there also has been the call for a need for an operational definition of a developmental and epileptic encephalopathy that can be utilized in clinical trials. So last year, or this year, it was published, a group of us got together to try and look at an operational definition of developmental and epileptic. And although these are the three key features, of course, for inclusion in clinical trials, there may need to be very specific features such as age of onset or a cap put on age of onset. But certainly looking at DEEs, they each should have frequent seizures and or EEG studies showing frequent epileptiform discharges, a history of developmental slowing or regression, and the underlying etiology known also to contribute to the developmental impairment. And also in the interim, we need to manage expectations. My experience now is that, yes, we're increasing in the number of diagnoses we're giving to the individuals with complex epilepsy in our clinic. But the key question next for families is their question to me. So what next? You know the cause, what are you going to do about it? And of course, we're not able to do anything about that in the short term in many. And we know that seizures will fluctuate in their frequency regardless of what we do for many. And therefore, we need to be aiming for optimal seizure control and minimal side effects as we move forward. There are many other aspects for an individual with developmental and epileptic encephalopathy seizures, not least the medication load, the cognition, the behavior, but also the family impact and peer relationships, sibling relationships. And we all need to remember that it's a holistic approach to these children that we need to give. Yes, being up to date on the most optimal treatments we can give, but also understanding what other input may be required as the families move forward. For the developmental and epileptic encephalopathies, the landscape is changing and changing rapidly. Improvements in diagnosis are allowing improved management algorithms, and enhanced etiological diagnosis will allow more aligned treatments. And ultimately, what we want is improved outcomes. By treating underlying cause, we feel we will move forward in improving outcomes, but that doesn't mean to say we don't optimize our medical treatment. Thank you very much.
Thank you, Dr. Cross, for such an expansive presentation. It's always helpful to hear everything. I'd like to open up any questions or comments from the chat from people following along online.
Want to sleep?
No questions at the moment. Okay. Well, thank you so much for your presentation. We really appreciate it, and we hope to see you again sometime soon here.
Thank you. Maybe I'll see some of you at Atlanta. Thanks very much.
Yes.